Hello and welcome to the second part of genitourinary emergencies. In this part, we'll talk more in detail about some of the specific diseases that you might come across in emergency department. Some are life-threatening, and at times you have to protect an organ within limited time. So, moving on to scrotal pain. Scrotal pain can be sudden in onset, gradual in onset, can be associated with other diseases that present with scrotal pain. Most important cause of scrotal pain is trauma. Moving on to some of the causes of scrotal pain. We now list them. First, it's trauma. As I mentioned before, scrotal pain, the most common cause of scrotal pain is trauma. Next, viral orchitis, for example, mumps orchitis, which is readily associated with peritonitis. So a patient where they might present with scrotal pain and usually they have scrotal atrophy. Moving on to urolithiasis, it is at times rare presented as a scrotal pain, but can be present with ureteric colic that can present with scrotal pain. So urolithiasis is stone in the urinary tract or the ureter. Moving on to incarcerated hernia. Incarcerated hernia is when inguinal hernia is incarcerated into the scrotum, and at times, you can hear an audible peristaltic movement. But when inguinal hernia is strangulated, you won't see or you won't appreciate any peristaltic movement in the inguinal canal and over the scrotum. So incarcerated hernia can present with scrotal pain when this incarcerated hernia is engorged or gets into the scrotum. Testicular torsion and epididymitis. They both have a similar clinical appearance, but one is an emergency condition and one is not that emergent as compared to the other one. Testicular torsion we'll talk in detail in the coming slides, and epididymitis as well, but they tend to present with unilateral scrotal pain. They might have a clinical features of tenderness, redness, and other signs and symptoms of torsion and epididymitis. The epididymitis have a sequelae complication of epididymal orchitis, which present with scrotal pain. The torsion of testicular appendages can also present with scrotal pain. Moving on to torsion of the testicles. I'll spend more time on this topic because this is an emergency condition. When you see a patient, these usually happen in men younger than 30. They present with sudden onset of unilateral pain associated with nausea and vomiting. At times, there might be an abnormal lie of the testicle, that is horizontal lie. That is called bell deformity. So the patient might have a history of similar scrotal pain. The diagnostic feature on physical examination of torsion of testicle is loss of chemostatic reflex. That is a classical finding you would appreciate in patient with a torsion of the testicle. What is the most important take-home key point for torsion of testicle is you have 6 hours to protect the testes. How to do that? You have to either detort the testes, or you have to go for a surgical exploration as well. But even with detorsion or manual detorsion of the testicles, you have to go for a surgery because there is high incidence of the testes going back to the torsion again. So history of similar scrotal pain, abrupt onset of pain, severe and unilateral, associated with nausea and vomiting. Tenderness initially in testicles, later spread to contiguous intrascrotal structures, and there might be reactive hydrocele in these patients. So testicular torsion. Moving on to what is the location or the direction of the torsion of the testicles. In left testes, the direction of torsion is counterclockwise, while in right it is clockwise. So if for manual detorsion, it is in opposite direction of the detorsion that is usually occur in the both testes. So they have different direction of torsion. As I said, with left, that is counterclockwise, you have to detort in clockwise. while right is in clockwise, you have to detort in counterclockwise. A 360-degree is recommended. So moving on to torsion of the testicular and or epididymal appendages. Of the 4 appendages, there 92% is covered by appendix testis and 7% is covered by epididymal appendages. Appendix testis is on the anterosuperior pole of the testes. So with torsion, they present with blue dot sign as a sign of ischemia or infarction. They have marked edema which obscure the examination, and they might have a reactive hydrocele. They present with a similar sign and symptoms of torsion of the testicle, that is unilateral scrotal pain, nausea, and vomiting. Moving on to torsion of the testicle, examination finding, which includes bell clapper deformity, that is horizontal lie of the testicle. Then there is abnormal position of the testicle in epididymitis. At times, because of the reactive hydrocele, there is increase in there might be an abnormal lie of the testes. Moving on to scrotal contents are swollen and tender. Again, swollen due to reactive hydrocele and tender because of inflammation. And with torsion of testicle and epididymitis, you cannot appreciate if the patient is going through a torsion of the testicle of epididymitis because the clinical appearance and feature is almost similar. With epididymitis, initially there is no swelling, but as the time progresses, there is increased swelling, and they might present with some clinical signs and symptoms of testicular torsion. So what is the treatment? Provide analgesia, prepare for surgery, and immediate urological consultation. Why is this so much important? Because you have to protect the testes, and you have only 6 hours to do that. Even if you do manual detorsion and the pain is relieved, again, you have to go for a surgery, because with manual detorsion, there is increased chance of recurrent torsion again and again. So within 6 hours, you have to protect the kidney and from infertility. Epididymitis, it might be a sequelae of a urinary tract infection, preceding urinary tract infection or urethritis. They present with pain that is gradual and less severe, but again can present with sign and symptom of torsion of testicle. Franz sign, that is when you lift the scrotum, there the pain goes away. There is increase or improvement in the pain. So Franz sign is an important sign in epididymitis, but it is not sensitive or specific for epididymitis, as compared to loss of chemostatic reflex is a classical sign of testicular torsion. On physical examination, you would find redness, tender, swollen, and the abnormal lie of the testis. And while you lift up, the pain might improve. Tender epididymis, reactive hydrocele. What to do? You have to go for a urine analysis and ultrasound, a Doppler ultrasound, to show the epididymitis. The sequelae of epididymitis is the patient might go into epididymal orchitis as well. So, differentiating torsion from epididymitis. Why do I have put this slide under this section? Because with color flow Doppler ultrasound, in testicular torsion, and there is no blood flow or reduced blood flow. When epididymitis, there is increased flow or color flow Doppler ultrasound. On the other hand, with the radiological scan, that is radionuclide scan, there is increased uptake by epididymitis and decreased uptake by the torsion of the testicle. So treatment: if testicular torsion present, obtain urgent urological consultation. Prepare patient for the immediate surgery. Manual detorsion, if your urologist is not available. So how to do that? You have to do it in 360-degree with the counter direction of the respective testicle, which is torsion. So detorsion of the testicle within 6 hours. Even with the manual detorsion, you have to proceed for a surgery. And in patient with suspected epididymitis or orchitis, urological consultation, if torsion of the testicular appendages, bed rest, scrotal elevation, analgesia, and follow up within 1 to 2 days. Or they might need a surgical excision. So moving on to painless scrotal mass lesion. In painless scrotal mass, most of the time that is tumor, and tumor testicular tumor is most common in young individuals. So we'll talk about 4 of them. That is spermatocele, that is this asymptomatic mass separating from the testicle, and with aspiration of the fluid, you might find a white fluid with immotile sperms. Then we have varicocele. Varicocele is asymptomatic and it feels like a bag of worms, and it is increased with Valsalva maneuver. With right-sided varicocele, there is high suspicion of inferior vena cava or intra-abdominal pathology. With left-sided, there is increased chances of renal vein thrombosis. Testicular tumor, as it occurred in young, asymptomatic, but need surgical exploration as well. Hydrocele is a collection of fluid which when on aspiration is clear, and there is increased transelimination, that is light passes through it and transeliminate. So hydrocele could be revealed on ultrasonography, and aspiration reveals clear fluid, and transelimination means the patient in hydrocele there is increased passage of the light. Testicular tumor, most common in young adults, asymptomatic enlargement of the testes, firm non-tender mass, gynecomastia or virilization can be present, or feminization can be there too. Diagnosis could be done on ultrasonography, but you need a surgical exploration to know the type and to do the biopsy of the testicular tumor. Moving on to orchitis. Orchitis, as I mentioned earlier in this lecture, orchitis presents with scrotal pain. It might be a sequelae of epididymitis, that is epididymo-orchitis, which is itself is a sequelae or complication of urinary tract infection. But orchitis is associated with mumps viral infection as well. With mumps, it starts off after 5 days of peritonitis, and it is usually present with peritonitis. That might be orchitis, might be unilateral or bilateral. But with mumps virus, the peritonitis is usually present with orchitis, and there is atrophy of the scrotum. Next is mycobacterial agents. For example, patients with urinary tract infections leading to epididymitis and complicated urinary tract infections leading to epididymitis and hence eventually leading to epididymo-orchitis can cause orchitis as well. Bacterial orchitis, again, the bacterial organism which can cause urinary tract infections leading to epididymo-orchitis. In epididymo-orchitis, there is increased tenderness, increased temperature, and the friend sign is positive. You tend to lift the scrotum and the patient feels relaxed. And that is why the scrotal support is also a choice of treatment in patients with epididymo-orchitis. And again, how do we diagnose? We do an ultrasonography if there is increased blood flow, increased color flow Doppler, or increased radionuclide scan uptake. This is an epididymitis or epididymo-orchitis. So what are the treatment options do we have? Analgesia, bed rest, and urological consultation. Priapism. Priapism is abnormal involuntary erection of the penis without sexual stimulation, and it does not go with ejaculation as well. At times with 25% of the diseases, it is associated with 25% of the diseases, which includes sickling hemoglobinopathies and leukemias and malignant carcinoma. It is also associated with recreational drugs or ecstasy drugs, which includes cocaine, marijuana, MDMA, and alcohol. So people taking recreational drugs can present with sudden involuntary penile erection. Priapism is of 2 types, high flow or low flow. Low flow is when there is increased pooling of the blood in the cavernous sinus. And what to do in this patient? You can aspirate to relieve the priapism. And what are the treatment options do we have? We can give analgesia, oxygenation, hydration, exchange transfusion, terbutaline, that is beta agonist, corporal inspiration, or sympathomimetic therapy. At times, we can use ice or cold packing as well, but it is not readily effective. Moving on to Fournier's gangrene. It is an emergency condition. What happens in Fournier's gangrene? It is a necrotizing fasciitis. It is most commonly in patients who are diabetic, immunosuppressive, history of trauma, perianal diseases, or alcohol intake or obesity. They start off with perianal region, the scrotal region, and they tend to move down and involve the entire leg or the hip. It is associated with fever, generalized edema, and pain. They are tender pain. There is increased mortality rate in Fournier's gangrene. 50 to 60% mortality rate with Fournier's gangrene. And what might be the cause? What is the important cause? That is bacterial infection, that is aerobes and anaerobes. So let's move on. The clinical findings include fever, edema, erythema of the scrotum, and pain. They have excruciating sudden pain, which start off with the scrotum and migrates to the entire leg involved. So it is most commonly in diabetic patients, and aerobes and anaerobes are commonly associated with it. What treatment options do we have? We have to give them antibiotics, analgesia, and most of the time these patients need surgical debridement. So antibiotic therapy, broad spectrum antibiotic therapy, and surgical incision and drainage. Moving on to dysuria. Dysuria is urgency and frequency and painful urination. It is common in many diseases. We'll explain further in detail. But most commonly, it is associated with urinary tract infection. Also, it can be with dehydration as well. Patients with low intake of the fluids can have signs and symptoms of dysuria. Sexually transmitted diseases can present with dysuria. Females during menstrual cycle can present with dysuria. But we'll talk about what are the causes of dysuria. Urethritis, infection or inflammation of the urethra, prostatitis, infection or inflammation of the prostate glands. Urethral stricture can present with dysuria because of incomplete voiding of the urine and increased retention of the urine, leading to dysuria and signs and symptoms of urinary tract infections. Urethral carbuncle, dysuria frequency syndrome, we'll talk about in detail. Vaginitis can present with inflammation of the vaginal canal, can present with signs and symptoms of dysuria. Genital herpes, external vaginal skin lesions, or genital herpes can present with signs and symptoms of dysuria. Urinary tract infection, again as I mentioned, is a common cause of dysuria. Urethral trauma can present with dysuria, and psychogenic patients can present with dysuria. Again, dysuria can be with fever or can be without fever. Dysuria is increased urgency, frequency, and increased burning of burning and urination. So dysuria in females, most importantly, females are more prone to get urinary tract infections because of the structural anatomy or differences of structures of the genitourinary tract than males. So they are more prone to get urinary tract infections. So collection of the urine, midstream clean voided urine is usually recommended to take. And how do you take it? Either we take a catheterization. For example, if you need if a female comes to you in emergency department and you need a urine sample and the patient is unable to void or patient is not feeling any urge to void, how do you do that? Even the option is to wait, or you pass in and out the Foley's catheter. A 9 French Foley's catheter is adequate because if you pass a bigger catheter, that can be a source of contamination and can lead to urinary tract infection. as a catheter, foreign catheter, is also the important cause of urinary tract infections. Otherwise, it's suprapubic aspiration. That is suprapubic aspiration. That's 2 centimeter breadth width of upward from the suprapubic symphysis, and you put a needle in and you aspirate the urine from the bladder. Why is suprapubic required, especially in patients with urinary tract infections? Because with indwelling catheter, you can disseminate the source or bacteria into the bladder and can cause some more complications as well. So moving on to clinical differentiation of the causes of dysuria in females. So clinical differentiation of dysuria, urethral syndrome and UTI, dysuria without vaginal symptoms. Why is the differentiation important? Because dysuria can be alone, but without vaginal symptoms is urethral dysuria, urethral syndrome. Dysuria without vaginal symptoms include no discharge, no dyspareunia, and no signs of pyuria. And there is the decreased leukocytes or white cell count on the urine analysis. But if there is pyuria present, if there is vaginal discharge present or increased white cell count, this is not a urethral syndrome. This is a urinary tract infection. So pyuria, bacteria in the urinary sediment, most likely a UTI. What are the local causes of dysuria in females? Vaginitis, which is exclusively in female, presenting with discharge, greenish discharge or whitish discharge, signs of inflammation, which includes tenderness, fever, pain, or genital herpes. External genital herpes can present with signs and symptoms of dysuria. Urethral caruncle can present with signs and symptoms of dysuria, and ureterogram is required to diagnose urethral caruncle. Dysuria associated with hematuria in either of the sex, that's hemorrhagic cystitis. Or concomitant urolithiasis. We'll talk about more in detail about urolithiasis, why is hematuria is an important diagnostic feature. We'll talk about more in detail about the hematuria in the coming slides about the atraumatic hematuria. But at this point, I want to highlight that if the patient is presenting with flank pains and hematuria is there in the blood, you must think of a stone, either renal colic or ureteric colic that is causing the blood in the urine, and that needs urgent treatment and urgent pain relief. Urethral manipulation can present with dysuria and signs of hematuria. Moving on to atraumatic hematuria. Atraumatic hematuria can be divided into two things: macroscopic or microscopic. Macroscopic, when you can see a blood in the urine, or microscopic when you see under the microscope. As you can see in this diagram, on the right hand side there is a macroscopic, as you can see the blood, the color of the urine. And the left hand side, on the left hand side, you can find microscopic hematuria, as the text shows, more than 3 red blood cells with high power field. What happens is, the most important cause of atraumatic hematuria is glomerular diseases, non-glomerular diseases, which covers the 25% of it. 20% is covered by the infectious diseases, and 10 to 15% is covered by the trauma or by the tumor. So non-glomerular diseases are the most important cause of atraumatic hematuria. We'll spend more time on the causes and what the treatment options do we have for those problems causing hematuria. But for now, I want you to know what do initial or a stream in macroscopic hematuria is really important. For example, if a patient comes to you with a complaint of hematuria or macroscopic hematuria, if it's on the initially, if the bleeding or hematuria is initially on while passing the urine, that is more likely to the anterior urethra. But if it's in the end or the terminal stage of the urination, that is due to a posterior or trigone area. But if the entire stream is red, or there is hematuria or macroscopic hematuria, that is that is related to a bladder injury that is posteriorly. So this is an important differentiating point. So in history points, you need to ask this patient, at what time did you feel this macroscopic hematuria? Moving on to causes. Malignancy is the most important cause of atraumatic hematuria. At times, with elderly males or females, they present with signs and symptoms of anemia, but and hematuria. What happened is because this is due to malignancy. It is said in the literature, in elderly males or females, if there is increase in painless bleeding or atraumatic hematuria, it is a tumor until proven otherwise. So patients present with even the complication of the tumor, but they don't know the treatment, or they don't know the diagnosis, or they don't know that these problems are due to the tumor. So malignancy is the most important cause of atraumatic hematuria, and that is painless hematuria. Drug-induced intestinal cystitis, cyclophosphamide, can cause interstitial cystitis and glomerulonephritis or acute tubular necrosis, which can lead to RBC cast cells, leading to atraumatic hematuria. Renal vein thrombosis can cause atraumatic hematuria as well. Glomerular diseases can cause atraumatic hematuria. For example, nephritic syndrome can cause glomerular diseases. Nephritic syndrome is a complex disease, and it covers multiple subtypes, which causes hematuria or blood in the urine that is atraumatic. It is differentiated from nephrotic syndrome, which is increased proteinuria, and this is increased RBCs in the urine. Renal artery embolization can produce atraumatic hematuria. Stones are important causes of hematuria as well. We'll talk more in detail about the renal stones or urolithiasis in the coming slides. Infection can cause, as I mentioned before, 20% of the atraumatic hematuria is covered by infection, and 25% is covered by glomerular diseases. Abdominal aortic aneurysm, a rare cause, but can cause atraumatic hematuria as well. So, history is very important in patients with atraumatic hematuria. We'll talk about abdominal or flank pain. Is there any tenderness? Timing of the hematuria, as I mentioned before. Initial, terminal, and total stream, as I mentioned before in the previous slides. And what the sites of bleeding from. Why are these questions very important? Because with abdominal or flank pain, and there is costovertebral angle tenderness, think of a urolithiasis or a renal colic, right? The treatment remedy, the treatment plan would change. You need to provide analgesics, go for a CT scan, and provide route or provide education or provide information about the patients or treatment options available for the patient. If there is tenderness, and where that is suprapubic tenderness, think of any inflammatory, pelvic inflammatory diseases as well. Timing of hematuria. As I mentioned before, if it's initial, terminal. If it's initial, think of anterior urethra. If it's terminal, think of trigone area. If it's total stream hematuria, think of a bladder. So anterior urethra for initial, posterior urethra or trigone area for terminal, or bladder source or beyond, that is with total stream hematuria. Hematuria associated with dysuria, urgency, and urinary urgency, think of hemorrhagic cystitis. Associated systemic conditions, thrombotic thrombocytopenic purpura can cause atraumatic hematuria. Henoch purpura can cause atraumatic hematuria as well. Sickling hemoglobinopathies can cause atraumatic hematuria. Excessive anticoagulation therapy or patients with coagulopathies, they present with atraumatic hematuria. So while taking the history, you need to find out what might be the cause of atraumatic hematuria. For example, if it's coagulopathy, you have to treat accordingly. You have to go for an INR or PT or prothrombin time, and you have to treat them accordingly to prevent the hematuria. So, urolithiasis. it is a very, very important topic and a discussion. Why? Because you would tend to receive these kind of patients every now and then. In an emergency department, with pain is a very, very important common presenting complaint. So with urolithiasis, it is an atraumatic hematuria. How does a patient present to you? Patient present to you with flank pain associated with nausea and vomiting, and the pain is going into the ipsilateral groin. There might be decreased urinary stream, but at times the stream is normal. So there might not be a fever, or might present with fever that is a complication of the renal colic leading to pyelonephritis, that is infection of the renal parenchyma. So how to approach in the patients? First and foremost thing you have to do is go for analgesia. How do you provide analgesia? You provide with NSAIDs and paracetamol. These two remedies I have experienced have a greatest effect on patients with renal colic. Although we can top up with opioids and other treatment pain analgesics that we have, but NSAIDs are the mainstay or treatment of choice in patients with renal colic. So how to proceed? Get a urine analysis. If there is hematuria, this is likely a stone. Get a helical CT if there is no contraindications. If there are no contraindications, go for a helical CT because it is diagnostic, sensitive, and specific as well. It will tell you the ready opaque and ready lucent stones both, and plus this will tell you the exact size and location of this stone and its effect on the kidneys. For example, hydronephrosis, that is back pressure leading to acute kidney injury or other problems. So, long-standing painless hematuria, intravenous pyelogram, or cystoscopy is advised. So, but if it's painless, cystoscopy is advised, intravenous pyelogram is advised as well. With intravenous pyelogram, they have some contraindication. If creatinine is more than 1.4, you do not proceed for intravenous pyelogram. Urinary tract, or it is useful in detecting urinary tract or bladder tumors or abnormalities. Infection, dysuria and pyuria. On urine analysis, you can see your leukocyte count or nitrites, plus you can see RBC. But you have to rule out RBC Castile that most occur in renal tubular necrosis, most commonly in patients with drug-induced glomerulonephritis. So urine culture shows bacteria, usually 105, more than 105 colonies. Think of urinary tract infections. But as I mentioned before, urinary tract infections can be complicated and uncomplicated as well. With uncomplicated urinary tract infections, there is mild symptoms which takes and relieves and goes away within few days after a proper antibiotic therapy. While on the other hand, the complicated urinary tract infections can lead to serious outcome. For example, with complicated urinary tract infections, patients tend to have epididymitis. Patient can have acute kidney injuries. Patient can have hydronephrosis and pyelonephritis. Who are the patients who are susceptible for complicated urinary tract infections? Patients who are elderly, patients with history of prostate or prostatitis, patients with history of recurrent urinary tract infections, patients with history of a catheter or they are bedbound, patients with history of diabetes, immunosuppressions. So these all are at risk of getting recurrent urinary tract infections and complicated urinary tract infections. And most of them needs admission even with simple leukocyte count or nitrates within urine analysis. So glomerulonephritis, it's commonly with post-streptococcal infection, that is throat infection, autoimmune diseases. It is gradual in onset. Hypertension can be present with it too. So prostatitis, dysuria is often present. It is the inflammation of the prostate glands, abnormal prostate position or tenderness of the prostate on rectal examination. Pyuria is often present.
One thing to remember, in patients with prostatitis, it is not recommended to pass a Foley's catheter or indwelling catheter because it can disseminate the source of infection to the other part of the body and can cause a further serious complication. So it is recommended to go for a suprapubic aspiration of the fluids of the urine, and do not go for a Foley's catheter. What other treatment options do we have? Analgesia, IV fluids, and antibiotics should be given to patients with prostatitis. Bleeding diathesis. Patients present with a purpura, a coagulation test is required. Thrombocytopenia or thrombocytopenia, especially patients with long-standing anticoagulation, for example, warfarin. Warfarin patients with AFib, with chronic AFib who are taking warfarin can present with atraumatic hematuria as well. So what lab investigations do we need? Urine analysis, serum electrolytes, renal function test, CBC with differential diagnosis, with differential count. Why is urine analysis required? To rule out RBC cells, to rule out leukocytes or nitrate counts, specific gravity in urine analysis. Serum electrolyte, to look for the signs of dehydration, look for the signs of any electrolyte imbalances. Renal function test. Why is important? To see if there is damage to the kidneys. For example, in a patient with urolithiasis or a patient with renal colic, there is high suspicion the patient might go into acute kidney injuries. We have talked more in detail about acute kidney injuries in the part 1 of this genitourinary emergencies, and we have talked about the stages of acute kidney injuries as well. Please do consider a part 1 of this lecture of genitourinary emergencies. But for now, why is renal function test important? To rule out any abnormality caused by any obstruction, any infection, or any other sort of diseases that can cause atraumatic hematuria. CBC with differentials to look for any acute neutrophil count or white cell count, to look for any hemoglobin, platelet count, to look for thrombocytopenia. So what special studies do we require in atraumatic hematuria? CT scan, cystoscopy, and radionuclide scan. Why CT scan is very important in patients with suspicion of renal colic. They are highly specific, highly sensitive, no contrast required, no signs of renal damage. As compared to ultrasound, there is that can miss a tiny stone that is not sensitive, not specific, right? But it is readily used in females or young reproductive females with reproductive ages or pregnant females. So CT scan is widely used in renal colic patients. Cystoscopy, flexible cystoscopy to go and see what might be the cause of recurrent urinary tract infections. Either that may be urethral strictures or any mass causing it, or any false tract due to any trauma. These are importantly used, but with atraumatic hematuria, cystoscopy is used for painless bleeding with no history of trauma, suspicion of tumor, or looking for urinary tract structures. Radionuclide scans can be used as in patients as special studies in patients with atraumatic hematuria. So what treatment do we have? Treatment options, how to approach. If there is hematuria, urine microscopy and cultures, CT IV pyelogram, and ultrasound or urine cytology. Refer to urologist. If ureteric or renal stones is seen, manage conservatively. Look for signs of sepsis, that is dehydration, decreased blood pressure, signs of AKI, acute kidney injuries, decreased urinary output, large renal or ureteric stone, renal impairment, or persistent or complications. What patient needs admission with ureteric colic? Patients who are still symptomatic, patients who are still vomiting and cannot take orally, patients with pyelonephritis, or patients with single kidney, patients with a renal transplant, patients with already patients with already a disease of chronic kidney, patients with acute kidney injuries. They need admission, they need evaluation and further treatment, or even they need a surgical exploration for the passage of that stone. Urethral malignancy, you refer to urologist, endoscopic investigations are required, or plus minus, you can go for a radical surgery. Benign conditions, refer to urologist, endoscopic investigations to confirm if it's a benign, and then can discharge home and for further follow-up in OPD. So, moving on to urolithiasis, we have talked much about urolithiasis in the previous slide as well. So let's go and review what we have studied till now. So they present with typical flank pain, either right side or left side. As you can see in this diagram, this young man is positioned his hand over the right flank. This is a typical pain of urolithiasis or renal colic. It is associated with signs and symptoms of pyelonephritis, that might be fever, decreased urinary output, or there might be tenderness in the abdomen as well. There is tenderness over the affected kidney, predisposing conditions. There might be bradycardia or tachycardia due to pain, bradycardia due to sepsis or hypotension, or acute kidney injuries, and nausea and vomiting is also a clinical finding or symptom that a patient presents with. Acute unilateral flank pain radiating to ipsilateral lower quadrant, it's a renal colic. There might be vasovagal syncope. What are the lab investigations do we need? Urine analysis shows our increased RBCs. Urine HCG in patients with who are pregnant, who are suspicion of pregnancy, should be go for HCG, beta HCG levels to rule out any pregnancy, and if there is, you need to rule out an ectopic pregnancy. Urine cultures, if there is sign and symptoms of pyelonephritis. Blood urea nitrogen, to rule out any acute kidney injuries, that is post-renal cause of acute kidney injuries. Serum creatinine levels, increase in creatinine levels is acute kidney injuries due to post-renal problems. Calcium, magnesium, phosphorus, and uric acid levels, if required, if the renal functions are deteriorated. So imaging, an unenhanced helical spiral CT. As you can see in this diagram, in picture A, there is increased size of the right kidney as compared to the left one. So this is hydronephrosis. As you can see, as I can move the cursor here, there is dilation. This is the ureter coming out from the kidneys, and this is dilated as compared to this one. As you see on the left side, this is a small lumen, narrow ureter as compared to this one. So there is increase in size of the ureter, which means there is obstruction and there is back pulling leading to hydronephrosis. As you see in this whitish dots on this diagram, this arrowhead, this is nephrolithiasis. These are renal stones. These are present in the renal parenchyma. And urethral stone, this is at the kidney levels. As we go down, this is a ureter. As you can see, this is a stone in a ureter. And you measure the stone, and then if the stone is too big enough to cause any further problems, this patient needs admission. And if there is this stone is less, it's ideally said less than 7 millimeter, this patient could be sent home with on tablets and analgesics. So ultrasound is required in patients with who are pregnant females. Intravenous pyelogram in patients, but it is contraindicated in patients with increased creatinine of more than 1.4. KUB is not that specific, but at times can show a stone as well. X-ray KUB. Treatment is confirmed stone, rule out emergency, that is AKI, sepsis, or decreased urinary output. Consider hospital admission. If the symptoms amenable to medical management, the patient could be sent home on medical management if the stone is less than 5 millimeter. Trial of conservative management. Weekly KUB radiographs. If stone passes, stone fails to pass within 2 to 4 weeks, you should report back. The patient should report back and see a urologist and needs admission. Renal stone or urethral stone more than 5 millimeter, you refer to urologist and give medical treatment, which includes tamsuline 400 milligram, 0.4 milligram at night, and analgesics, which includes NSAIDs and paracetamol. So we talked about
many of the diseases include which involve genitourinary emergencies. We started off with scrotal pain, and most importantly, we covered the main topic of testicular torsion, how to assess, how to treat, and what to do in emergency. Then we talked about painless masses, which includes volvulus, which includes spermatocele, varicocele, and hydrocele, and tumors. We then talked about atraumatic hematuria. We talked about in detail about urolithiasis and what are the complications of urolithiasis when you come across an emergency department. That's all for now. Thank you for watching sqadia.com.